Hello everyone, my name is Maria Anastasiou. I'm a hematologist and today I will present you an interesting article on the risk of bleeding with low-dose aspirin prescribed for primary prevention of stroke. Aspirin is a cyclooxygenase 1 inhibitor. It also blocks thromboxane A2 on platelets in a reversible fashion, thus preventing platelet aggregation. Therefore, aspirin is widely used for primary and secondary prevention of cardiovascular events. The most important adverse event of aspirin is bleeding tendency. Evidence of efficacy of aspirin in primary prevention of stroke comes from meta-analysis and major trials conducted in people younger than 70 years. However, older individuals have an increased susceptibility to head trauma as a result of falls, and also an increased fragility of small blood vessels. Taken together, these considerations raise the question of whether long-term daily low-dose aspirin affects the incidence of stroke or intracerebral bleeding in older adults. This article, published in JAMA Network, presents results from secondary analysis of the ASPRI study. It is a prospective, randomized, double-blind, placebo-controlled trial of daily low-dose aspirin conducted among community-dwelling people living in Australia or in the US. Participants were adults 70 years old or older, free of symptomatic cardiovascular disease. Median follow-up was 4.7 years. 19,114 participants were recruited between 2010 and 2014. Over 9,500 participants were randomized to each one of the two groups, the aspirin and the placebo group. The primary outcome of the ASPRI study was disability-free survival, defined as a survival free of disability and dementia. The incidence of stroke and hemorrhagic events were predetermined secondary endpoints. Ischemic stroke occurred in 1.5% of participants receiving aspirin versus 1.7% of participants receiving placebo. There was a non-significant decrease of 0.5 events per 1,000 person-years. Additionally, there was no evidence of a differential effect of aspirin across the subgroups of age, sex, smoking, diabetes, dyslipidemia, frailty category, hypertension, or country. Likewise, the rate of hemorrhagic stroke was 0.5%, and it was not statistically significantly greater than that with placebo, that was 0.4%. In contrast, the totals of stroke and other categories of intracranial bleeding were significantly greater among individuals treated with aspirin and was calculated at 1.1%, compared with those receiving placebo with a rate of 0.8%. So the main finding of the secondary analysis was an increase in intracerebral hemorrhagic events, which outweighs a smaller and non-significant reduction in ischemic strokes. Overall, these data challenge the role of low-dose aspirin for the primary prevention of stroke and suggest that caution should be taken when use of aspirin in older persons prone to have a head injury. What I liked about this paper is that it's a large-scale study with over 19,000 participants that studied the risk-benefit ratio of aspirin exclusively in older participants in a prospective and randomized manner. Statistical methods are robust and results are highly relevant in clinical practice. One limitation could be the fact that fewer than expected stroke and bleeding events occurred during follow-up, and there was a lack of detailed investigation of stroke occurring in some of the participants. Furthermore, results are only generalizable to a wide population that has access to routine blood pressure and lipid controls. In conclusion, data of the secondary analysis of ASPRI study support the recommendation for non-prescribing aspirin as a primary prevention of stroke in healthy older adults. That's all for now. Thank you very much for listening or watching.